in the TU Moodle already, and today, after we end on this topic, I'm gonna randomize the case study to each group by, I have some lucky wheel on my phone. I'm gonna tap on this, and you could surprise which one is gonna be your belonging case study. Um, เหลือใครเนี่ย I think Shanisla doesn't join this meeting now, right? Shanisla, if you here, please reply me back. All right, so for all right, so please follow the Shanisla to join this meeting room. If she not appear in this meeting room in 9:05 a.m. So I'm gonna get her a 0 point of the class attendance in this topic. I'm not sure because I'm not, I don't get any notification from her. All right, so Shanisla, you are here, right? Hello, I see you.
Yes.
Okay. All right, so we're gonna start this fifth topic that I'm gonna tell you about pharmaceutical agents and some advanced instruments in cath lab that Ho Sin Shi doesn't tell you before about those kind of equipment. Oh. All right, so can you see my slide? No? Okay. So I'm gonna start. Okay, so I'm gonna about the objective of this topic, topic 5 here from 9 topics. So this is the halfway of the lecturing session. The purpose of this topic, I would like you to understand the basic knowledge about drug mechanism and some kind of administration in cath lab. But anyway, I don't want you to remember all these drugs that I'm gonna tell you in this topic. It's just some important that when you are being the scrub nerd or when you be circulating, or sorry, when you are be the scrub technician or circulate technician, you have to manipulate or give those drugs to the patient. So some drugs that like a little kind of that I would like you to remember. But anyone or other drugs in this topic, I just I need you to know just some basic knowledge and basic mechanism, some kind of that. And for the second purpose of this study, like I told in this topic, I include two story. The first one is about drugs, right? And the second one is about some advanced instrument that Hong Xin Chi, the guest speaker from Singapore, doesn't tell you and didn't tell you about those kind of instrument. So it leads to the second objective. I would like you to understand some, basic principle and how can we use those kind of advanced equipments in cath lab. Oops, sorry. All right, so let's start with the pharmaceutical agents in cath lab. Here in the list, as you can, if you see here, so you might familiar with this, you might learn about this before when you study on the second year. I'm not sure about that. Maybe on the bio or clinical side, something like that, right? So here on the screen is about the drug that often administered in heart disease. But anyway, there's a lot of drugs that the list that I show you on the screen is just the example that mostly used in cath lab, like mostly find in cath lab in both in the elective case or emergency case or just some critical event happen in the cath lab and we need to resuscitate the patient now in the cath lab, something like that. So here is some example of the drug or agent list that often used in the cath lab. And you can see here the first one is the anti-arrhythmic drugs. So it is important, right? Because if the patient are doing the procedure, or if interventional cardiologist doing the procedure and the problem access to the patient, like ventricular tachycardia or VT or ventricular fibrillation or VF, some kind of that. So the defibrillation or a shock to the patient might not resuscitate the patient right now. So in case of this, the doctor may give the anti-arrhythmic drug to stop those kind of VT and VF. And the second one is the vasodilators. Vasodilator is one important drug that often used in the cath lab as well, because in some case that the patient has just like when the doctor decide to approach to the coronary artery through the radial artery, right? In some patient, right, the elder female that has a tiny body in those type of patient has some really small radial artery and eventually brachial artery as well. In case of this, it might be a chance that has the vasospasm. It's just like when insert the catheter through the artery, the catheter stuck in the brachial artery or something like that. So the doctor may give the patient such vasodilator to dilate those vessel, like make a lumen wide open for easily insert the catheter and reach and finally eventually reach to the synod of Valsalva or ascending aorta. And about the third one is the inotropic ducts. The inotropic ducts is about a drug that can induce or increase the contractility of heart muscle. Or in some case that, the patient have the low LVEF, it's like low left ventricular ejection fractions, or, has the less wall motion, some kind of that. So the doctor or physician might provide this kind of inotropic ducts to the patient to increase the strain of the heart pumping, and eventually it's also increase stroke volume, right? Because eventually stroke volume, it came from LV DP and LV SP, right? Okay, and I'm sure about you can remember that or not. But anyway, eventually if the doctor give the inotropic ducts to the patient and it can increase stroke volume, finally it can increase the cardiac output as well, and improve the blood pressure in case patient have the hypertension, some kind of that, by doing the procedure. And And the fourth one is about chronotropic ducts. The chronotropic duct is about the drug that accelerate or increase, or in other words, it just decrease the heart rate or heart rhythm. All right, and the fifth one is about diuretic ducts. And the diuretic ducts is about the drug that used to expel or used to excrete the excessive fluid in the patient body. Is normally used in the patient that suffer with a congestion heart failure that have enough of a lot of the preload, right? Or just edema throughout the body, that's a lot of volume stuck on the right side, some kind of that. So it will, take the excessive fluid out from the patient. And the last one is about anti-platelet drugs. The anti-platelet drugs is really important because in this course, I would like to tell you about the cath lab life and a general procedure that always do in the cath lab is about the CAG and PCI, which directly treatment the coronary artery disease, some kind of that. So the anti-platelet duct is really important to prevent the clot formation throughout our body as well. And I'm gonna go for the first one, that about the anti-arrhythmic drugs. The indications of anti-arrhythmic drug is about use for restoring the heart rhythm, that from the irregular rhythm, some kind of that, and also the electrical conduction as well, and is also used for preventing serious arrhythmias to reduce high-risk mortality, like SVT or some kind of that. And about the pharmacodynamics of anti-arrhythmic drugs is to accelerate or reduce conduction velocity. And the second one is can suppress automaticity. It's like spontaneous, or it just spontaneous excitation, some of some cell that generate action potential, some kind of that. And the last one is about to change the excitability in abnormal cell. Before we know about the mechanism of anti-arrhythmic drugs, so I would like you to know about what is the arrhythmia. So when we talk about the arrhythmia, we have to know about what is the electrical conduction system. It's like really physiology. It's like cardiac heart physiology a lot, and I know you might learn about this on second year, right? All right, so I'm gonna tell you in brief about the first one that generate the electrical conduction, generate the electricity in our heart is the SA node, the sinoatrial node, that located in the right atrium below the SVC, right? And after that, the electricity will spread through the atrium from right to the left, and after it will gather together again at here at the AV node, or the anteroventricular node. Something it stands for anteroventricular node. And after that, the electricity will conduct through the bladder of His and branch, then split out to the left and right button branches, and after that it comes to the Purkinje's fiber and myocardial cells. And here is the picture that show you about the action potential of the of the excitability of some in the electrical conduction system, which has the two main types at the pacemaker cell, or SA node or AV node. So the action potential would be the slow response action potential, which we will see that on the right picture here on the graph C. So the major electrolytes that can cause the depolarization of this low response action potential is calcium, right? But anyway, other part of the heart, beside the pacemaker cell, you will see that the excitability waveform is the fast response action potential. It has some and it will has the waveform like this. You will see, and you will see that the electrolyte that relate to this fast response action potential is the sodium ion. You will see that when the sodium ion opens, so sodium ion from extracellular influx into the cell, right, and it's caused the rapid depolarization, and the cell membrane resting gonna be more positive rather than the negative. I know that you can remember that. And about when we talk about the cause of arrhythmia, so the cause of arrhythmia is varies depend on individual patient. And the first cause is about electrolyte disturbances. It's just like when our body lack of sodium ion, so in case of this, our body may respond to that position, like have the slow heart rate or have the the hypertension, some kind of that. And the second cause is about decreased oxygen delivery to the cell. Like, if we have, if we have insufficient oxygen or nutrients to generate this kind of activity, so yeah, it come to the arrhythmia at eventually. And the third cause is about structural damage on conducting pathway. And the fourth one is about acidosis or accumulate of waste product that also, directly disturb the cell metabolism as well. And the last one is about drugs that, some drugs that also altered the action potential, some kind of drug that, reflects or impact on the ion channel changing, some kind of that. And when we talk about the anti-arrhythmic drugs, so the anti-arrhythmic drugs generally classify into four major classes, as you can see here on the right pictures. And the classification of anti-arrhythmic drug depends on the action of the drugs on the ion channel of the cell membrane. You can see that the class 1 is about the sodium channel blocker. It just block the influx of the sodium into the intracellular, right, through blocking the sodium ion channel. In case of this, it will reduce the excitation of the electrical activities, like action potential, some kind of that. And in the class 1, it can classify into 3 subclasses, as you can see here: class 1A, 1B, and 1C. And I would like to tell you that you don't remember this kind of drug names at all, because it's quite we not just have the have the authority to give this kind of drug diary to the patient. I just let you to know about what is the anti-arrhythmic drug, something like that. And when we look at the class 2 about the anti-arrhythmic drugs, is the beta blocker. The drugs that belongs to the beta blocker, it has the action of beta blocker is propranolol or metoprolol, something like that. In this class, so due to it block the beta channel or beta receptor, right? In case of it, it will increase the refractory periods. In case of it, it will slow, like prolong the duration of action potential, and eventually it can reduce the heart rhythm or heart rate, like reduce the amount of excitation of action potential, some kind of that. And when we look at the class 3, it's about potassium channel blocker. The drug that belongs to the class is amiodarone and sotalol, something like that. And in this class, the drug will, inhibit the potassium ion, efflux from intracellular to extracellular. Did you imagine about that? All right, so when the drug block this channel, so the potassium will stuck inside the cell, right? And it will increase the duration of the plateau phase a bit. So in case of this, it will increase the duration of excitations, retard the refractory periods, if we look at in the other word. And about the last class is about class 4 is about calcium channel blocker. The drugs that belong to this class is verapamil or diltiazem, some kind of that. Normally the drug in this class used to reduce the heart rate, like it directly action on, or it directly take an action on the slow response, like to the SA node or AV node, some kind of that. And when we look at the subclasses of the class 1, that is the sodium channel blocker, right? You will see that for the class 1 also defined into 3 subclasses that I already told you about that. The class 1A is moderately depressed the phase 0. You can see the pictures. It just slightly inhibit the sodium channel ion opening and prolong the action potential duration. And about the class 1B is slightly, really slightly depressed phase 0, the phase that have the rapid depolarization, not directly blocked to the sodium channel ion. But anyway, it has the ability to shorten the duration of action potential that you can see on the graph by some, consensus no or consensus and no actions, something like that. And about the last class is about class 1C. It strongly depays phase 0 as well, and you compare when you compare to the class 1A, it's really strongly depays the phase 0 of the rapid depolarization, strongly inhibit the sodium channel blocker and resulting in extreme conduction slowly. All right, so I'm gonna move to the vasodilators. The vasodilator, like I say before in the previous slide, that used to dilate blood vessel by relaxing vascular smooth muscle tone that affect to the vascular smooth muscle cell. And eventually when the drug was given to the patient, right? So the drug will affect on the vascular smooth muscle cell relaxation, and eventually when the the vessel dilates, so it can decrease the peripheral vascular resistance and eventually increase blood pressure, decrease blood pressure. And when we talk about the pharmacodynamics of vasodilator, is really various, depend on the individual drug types. As you can see, is a lot of action, a lot of things. But anyway, in this topic, in this section about vasodilator, I will tell you just some type of the vasodilator, which is the nitroglycerin or NTG. NTG is the normal drug that used to treat the angina pectoris in the patients. Like have the chest pain, and you will see that you will heard about that when the patient have the chest pain, patient have to take the NTG sublingual, some kind of that, to relieve the pain, right? Because NTG, like I say, has the ability to dilate the vessel, right? in case the patient had angina pectoris, some heart disease, it caused from the mismatch between oxygen demand and oxygen supply, right? Like the heart may be, lack, it may cause for many various things, like the heart muscle maybe need more energy. So in case of it, you may provide just some entity or vasodilator to dilate the vessel to provide or provide or perfuse more blood to that tissue to balance between oxygen demand and oxygen supply. But in some other words, that some vessel might be has some lesion like plaque or atherosclerosis that cause the CAD, like coronary artery disease, right? Some case of that it also causes the mismatch between oxygen supply and oxygen demand as well. Like you will see that the heart muscle is just have the general or have the normal demand, right? But anyway, the supply is decreased, like the coronary artery stenosis or has some plaque that occludes the blood perfusion. So in case of this, the oxygen delivery is decreased, right? In case of this, the NTT may provide in the patient to dilate the vessel to recover the perfusions, and eventually it can balance the oxygen demand and supply. Do you imagine about that, right? And when we look at the mechanism of the nitroglycerin or NTG, like NTG is the substrate that is can, sorry, that it can interact with mitochondria aldehyde dehydrogenase 2 to become the nitric oxide. I know you might familiar with this name, like nitric oxide is very, substrate for, making the vascular tones. Like it's the key substrate that can make the muscle contraction or relaxations by binding to the myosin LZ phosphatase. And again, you don't remember this kind of name that exists on the screen at all. It just, I would like to tell you just some brief idea, and I hope you, understand well about NTD. And you will see that if we provide more NTD, it will generate a lot of nitric oxide, and eventually it will bind more to the myosin LZ phosphatase, and eventually it causes the relaxation eventually, as you can see, more, and it's caused the relaxation. Just remember this key point. I know it's just tough story as well. And you will see that in this right picture on this corner, you will see the route that the NTT will be given to the patients. The action of NTT is very short and lasting action. Is rapidly absorbable bruise. Like, normally the NTT will give through the sublingual or oral spray or intravenous in case the patient have the acute angina or angina pectoris, like I mentioned before, or in some patient who has the, persistent hypertension that not, reduced by using any drug. So NTT might be used in this kind of patient. And in the long-term prevention, the NTT may be used as the transdermal patch. It's like a patch that contains the NTT and, stick on the patient's skin, and the drug will release, gradually release and continuously release to the patient, like to the vein and absorb, something like that. And topical ointment as well is like a patch, but anyway, it come from come to the term of the ointment. And the last one is about annual fissures, but I'm not sure in Thailand has this administrate the entity to reduce or not. I'm not quite see this rule in Thailand. Anyway, and here here, this slide, I would like you to remember this. It's very important for us when we are scrub technician or a circulating technician anyways, because NTG is frequently used in cath lab. Like I said before, when you see the vasospasm, the interventional cardiologists will give the NTG, right, to dilate the constricted vessel, something like that. And the entity will be given into intra-artery to relieve vasospasm, like I said before, while inserting the catheter or diag guide wire on 0.035 inch guide wire that used to introduce the diag catheter or guiding catheter to reach the aorta. Don't worry about the equipment, so I will tell you more detail about the important or essential equipment for CAG and PCI in the laboratory or in the practical laboratory next week. And the entity will be given to the intracoronary as well to retrieve the slow flow in coronary. Right, remember that when the interventional cardiologist inject the contrast media and use the pedal, hit the X-ray to generate the radiation and hit to the patient, right? And you will see the image show on the screen in front of in front of us or in front of the doctor, and doctor will see that, oh my gosh, the flow, the blood perfusions to that kind of artery is so slow, like slightly slow, and the patient, the doctor will have some criteria to evaluate the flow, like the TIMI flow that has the 4 classes, 0 to 3. 3 is normal, 0 is just no flow, something like that. And I think about the TIMI flow, Ajahn Manpet would tell you about this next week about in the topic CAG and PCI basics to complex. All right, so when the patient see the blood perfusions slightly slow or have slow flow, the doctor or physician may use the NTG directly inject to the intracoronary to see again, like inject, and after that the doctor will inject the contact following the NTG giving and see what's happened to the flow. Like what happened to the coronary blood flow. In case of it, when the doctor look at the senior image after giving the entity and see that the blood perfusions is coming back to the normal, so that's it. There is no problem with that. But in case the blood perfusions in coronary artery will slightly see slow, so the doctor may use other decision, or may make another decision to do or to manipulate with that vessel. and generally the entity or nitroglycerin that normally used to inject into our body may contain in the sunlight protection vial, and you can see that because the light can degrade the NTG structure, and you will see that in each company will label about the content of the NTG in the fluid. In case of this, you will see that this vial contain of 50 milligram per 10 milliliter NTG. It's like the concentration of NTG. So you can see that 1 milliliter composed of 5 milligram, right? And normally the NTG that used to inject into the patient is just like only the 100 microgram, just on slightly a little bit amount of NTG concentrations when compared to the concentration in this bottle. So you have to dilute it. So the easy way to dilute is just like 1 milliliter equal to 5 millicum, right? So the 5 millicum is equal to 5,000 microgram. So in case of this, you have to draw NTG from this vial just only 0.2 milliliter. And then you will dissolve that with the 9.8 milliliter of normal saline that's already composed of the heparin. And I will tell you later on about the dose of heparin that need to compose in the normal saline again. And after that, you will get the 1 milliliter of normal saline mixed with NTG in concentration 100 microgram that normally will be given to the patient both in intra-artery and also intra-coronary. And the last one is about the NTG that used on sublingual, but as like a tablet. Normally, concentration of NTG that use that give through this loose is about 0.3 to 0.6 milligram because it have to absorb through the tissue, right? So the concentration might higher than directly give to the blood vessel. And the adverse effects of NTGs, right? For sure that of course the NTG directly dilate the vessel, right? So it might cause the hypotension in some patient, and it might cause the HH or syncope in some patient as well. And I'm gonna move to the inotropic ducts. For the inotropic ducts, the indication for using this kind of duct is to use for increasing cardiac contractility, like I told you earlier. Also used for increasing cardiac output as well. Like I told you that when increase the contractility, right, it will increase the stroke volume here and eventually increase cardiac output. And here is the mechanism of inotropic duct. Normally it will increase the calcium ion influx into the cell that can bind to the myosin, actin myosin, and it has increased the strength, increase the strength of the heart contraction, something like that. And I'm gonna move fast about the inotropic ducts because it's very I think it's a lot of things to talk about this. All right, so another one is a chronotropic ducts. This drug is used to, increase or decrease heart rhythm or heart rate. It's like, it's like relate to the anti-arrhythmic drugs as well in some part, but anyway, some kind of drug in this chronotropic drug is different from anti-arrhythmic drug. You might be confused about it, but anyway, the indication for using the chronotropic ducts is for increasing or decreasing heart rate or heart rhythm, like I say, depending on the action of drug types. In case the chronotropic ducts that decrease the heart rate or heart rhythm, we will call the negative chronotropes. But anyway, in case the chronotropic ducts that increase or enhance the heart rate or heart rhythm, we will call those kind of ducts as the positive chronotropes. And just in this topic, I will tell you just only the positive chronotropes, which is atropine and dopamine, which normally found in cath lab in case the patient need to be resuscitated from some critical event. The brief action about atropine. I'm gonna go for atropine first. atropine, the action of atropine is to, inhibit the acetylcholine, right, on the vagus nerve. Like I know it's just like the story from the second year again in physiology that vagus nerve control, like our heart control from both two kind of nervous system, right? Parasym and sympathetic. For the parasym is controlled at the vagus nerve, right? And for the sympathetic is controlled by CNS, something like that. And you will see that the vagus nerve is the parasym that already reduce the heart rate. In case we give the atropine to the patient, so the atropine will inhibit some action of acetylcholine and eventually it will suppress the parasympathetic action. In case of this, the dominant will come to the sympathetic nervous system and eventually it can increase heart rate or heart rhythm. And another one is dopamine. Dopamine is directly parameter that related to the sympathetic nerves, right? So in case we provide a lot of dopamine, exactly, of course, it will increase the sympathetic actions. So in case we give the dopamine to the patient, finally, it will increase the sympathetic nerve dominant and increase heart rate or heart rhythm eventually. All right, so I'm gonna move to the diuretic ducts. The diuretic ducts is also important ducts that used in congestive heart failure or patients suffer with the edema or something like that. The indication for using diuretic duct is to reduce high blood pressure or reduce the excessive fluid in the body. Like, some other disease like liver disease or liver cancer, some kind of that you may see the ascites, like with just like, the patient's stomach just really big, something like that, that has some excessive fluids in the intraperitoneal cavity, some kind of that. Let you imagine about that. In Thai, we call โรคท้องมาร from the liver disease. So in case of this, the doctor may provide the diuretic duct as well to, excrete the excessive fluids in the intraperitoneal cavity of the patient out. Okay. And in case the heart disease, when we look at the congestive heart disease, right, when you have the heart function is very poor, so the the volume, the blood volume mostly stuck in the lung, right, in the pulmonary artery, some kind of that. So and cause of the right side of the patient's edema. So the diuretic duct is also used in this patient as well to eliminate the excessive fluid, like excrete the excessive fluid. So the main point of the diuretic ducts, like mostly diuretic ducts, inhibit sodium reabsorption at the nephron in our kidney. Eventually, if the sodium doesn't be reabsorbed back to our body, right, the sodium will be filtrated through this kind of nephron, like the rumen of the nephron, and excrete out as urine, right? And due to a lot of sodium in this tube, it can cause the hypotonic in the nephron, and eventually the fluid or water that's surrounding this nephron, like on this kind of tissue, will be excreted out or will diffuse through this tubule and going out to the urinary tract as well, like increase water excretions depending on concentration gradient. Here is the key point of the diuretic duct, but not 100, but not mostly, just some part of the diuretic duct, except the mannitol. The mannitol function of the mannitol is normally, like effect on the water excretion, not just, block the sodium ion reabsorption at all. And the diuretic duct that normally found in cath lab is Lasix or furosemide. The action of furosemide is effect at the loop of nephron. At this point, the furosemide effect at this point as the loop diuretic duct inhibits the sodium and potassium ion channel that will take sodium and potassium channel that will take the sodium and potassium back into our body. So in case we provide the furosemide in the patient, furosemide or Lasix will block this channel, and it's cause the the sodium not reabsorb back to our body. The benefit of furosemide and Lasix is to decrease fluid volume, like I say, and also reduce blood pressure as well, because that blood pressure has many factors that affect to it. Besides of the peripheral vascular resistance, the volume in the vessel also causes the high blood pressure, right? In case high amount of volume is also increase the blood pressure. In case we can reduce the volume in the vessel, it also reduce the blood pressure as well. And the furosemide also reduce the afterload as well, like reduce the volume, reduce the peripheral vascular resistance or afterload, and it eventually reduce preloads as well, because it reduce the volume from artery, right? So the volume that will turn back to the right side of heart, to the SVC or IVC, will be has the low amount as well. So in terms of this, it will we can assume that it also reduces the preload as well. And about the side effect of the furosemide is, when we look at the central nervous system, it can cause the patient dizziness and headache or blur visualize as well. And about the GI tract or gastrointestinal tract, it can cause the patient nausea, vomiting, or diarrhea in some case. And in terms of metabolism, so it can cause the hypokalemia, of course, because it's blocked the potassium reabsorption, right? And it's also hypoglycemia, because blood sugar in our vessel has high concentration, so it could cause hypoglycemia eventually. And it also causes the hyperuricemia as well, like have the uric acid a lot in our vessel. And we're gonna move to the anti-platelet drugs. All right, for the indication for the anti-platelet drugs, it's used to prevent blood clotting. And you will see here is the mechanism of the actions. Here is the platelet, right? When you know that the platelet will be activated when the vessel has some damages or rupture, or had some something like that something that rupture to the vessel, and the platelet will be aggregated to each other to stop the bleeding or cure the ruptured tissue, something like that. And you will see that there are various kind of mechanism of the actions of anti-platelet drugs. For example, it will inhibit thromboxane A2 like aspirin, which accounts as the indirect effect on the platelet activation, or it can inhibit the P2Y12 ADP receptor, and eventually it can inhibit the platelet aggregation as well. For example, clopidogrel or prasugrel, some kind of that. You might familiar with this name. And some other type of anti-platelet drugs also inhibit the DP2B3A receptor. For example, abscizumab or tyrofibane, something like that, that will inhibit this kind of receptor that has something like bind with each other to another platelet cell and form the fibrinogen that act as the like a hair that can gather every compound or a protein component together to forming a clot. And some part of anti-platelet drug can inhibit the PDE and also inhibit the PAR1 receptor as well. Normally, the normally anti-platelet drugs that normally found in cath lab would be an aspirin that have the direction that have the mechanism on the thromboxane A2, like inhibit thromboxane A2, and another one is clopidogrel and prasugrel that has the action on the inhibition of P2Y12 ADP receptor. And when we talk about hemostasis, you might wonder that why the antiplatelet is very important for cath lab, especially in the CAD and PCI procedure that use the catheter inserting through the artery, because the key point is the foreign body can activate the fibrotic formations. As you can see in this picture, here is the foreign body after it comes to our body. The body has some response to this foreign body, like not familiar tissue. All right, so many protein will binding to the material, like binding to the catheter, and eventually it will recruit the neutrophil, it will recruit monocyte and differentiate into macrophage, and it form the foreign body giant cell formations, like I think like that, and already includes such a lot of cytokine and protein compound to form the fibrotic encapsulates, and eventually our body will detect that this is the extracellular extracellular matrix. It's just like the rupture tissue or not, that's like fibroblasts exposed to the bloodstream, so it will recruit the platelet and other compound or the factor that relate to the coagulation, and eventually it will form the clotting. So in case CAD and PCI, so some anti-platelet drugs or may have to provide in the patient before doing the procedure to prevent this event or this circumstance. But anyway, you will see that normally the hemostasis will come from the will begin step by step, right? You will see that it becomes when it begin that the vessel injury, and after that the vessel will be constricted, and the platelet will be aggregate with each other to form to occlude the injury site, and after that it will recruit the protein compound, or fibrin or thrombin, something like that, to form the clot that we call as coagulation step. And here is the is the pathway of the coagulation, or we call that coagulation pathway, that will be activated by intrinsic pathway, the damaged vessel, or the extrinsic pathway that exposed to the fibrous tissue, something like that. All right. So when we look at the antiplatelet, so an antiplatelet will have the action on just this section of the hemostasis, on the platelet plaque formations, like inhibit thromboxane A2, inhibit PAR1, or inhibit the P2Y12, something like that. So you might see that antiplatelet just only prevent the platelet aggregations, but it eventually can prevent the coagulations, but it doesn't have enough powerful to inhibit entire of the blood clot formation. So the anticoagulant drugs might be additionally provide to the patient who have to do the PCI. For example, some drug that inhibit the coagulation pathway of this. And it comes to the anticoagulant drugs. For anticoagulant drugs, for example, the drug that you might familiar with this is about heparin. Heparin is one type of the anticoagulant drugs that mostly used to inhibit many factors in the coagulation cascades that I already told you about, the intrinsic and extrinsic pathway, right? You can see that heparin can inhibit many factors, many steps in this coagulation cascades. You will see that. So we can account that heparin provides the strongly powerful anticoagulant. So it leads the heparin generally used to prevent the clot formations. But in other hand, so the heparin might provide a higher risk of the bleeding as well. As you can see, it take action on really factor in this coagulation cascade, right? So in the patient has some problem, like has some rupture, so it can cause the excessive bleeding eventually, like a lot of excessive, and we can stop them. Except you will have the antagonist to this, like vitamin K or something like that. And heparin can be given through intravenous or subcutaneous, depend on the doctor consideration. And why I have to talk about heparin? Because like I told you that in cath lab, especially in the CAT and PCI procedure, heparin is generally used to prevent the blood clotting or blood clot formation. Why doing the procedure? Because the equipment that we insert into the patient is account as the foreign body, right? And it will, recruit many factors that can affect, cause the coagulation eventually. So the heparin will use to prevent that kind of action. In cath lab, heparin will be given through sheet before performing the PCI. And normally, we will give the heparin to the patient about 100 units per kilogram. So in case the patient, the weight of the patient weight is about 80. So the amount of heparin or the dose of heparin that we need to give to the patient is about 8,000 units, right? Because the weight of patient is about 80 kilogram. And the ACT or activating clotting time must be over 200 seconds prior to conducting PCI. After you give the heparin, you have to collect the whole blood and taste the activating clotting time. After you taste the activating clotting time and you see that the blood clotting time is over 200 seconds, so you can doing the procedure further. And the 5,000 units of heparin may be given again to the patients after the doctor doing the PCI over 1 hour. But anyway, after doing the PCI for 1 hour, the ACT must be evaluated. Like the blood from the patients must be collected and taste the ACT to ensure that the clotting time already exceeds the 200. Like I say in the previous slide that give a lot of heparin is not good for the patient. It can cause the excessive bleeding, right? So when we're doing the PCI, like when the doctor doing the PCI over 1 hour, but anyway, it will finish soon, like in 15 minutes or something like that, not over 1 hour again. So the doctor might not give the heparin to the patient again, even it exceeds the 1 hour for about the PCI doing time, because it can cause like when we have to stop the bleeding from the puncture site, it can cause the bleeding and eventually cause the hematoma as well in some patients. But anyway, the additional information about it, I think Ajahn Vanpet might tell you about CAG and PCI later on in next week. And in case the patient suffer or has the STRMI post-SK, SK is a streptokinase that accounts as the fibrinolytic agent. I will tell you about this kind of drug in the next slide. Maybe the heparin might not be given in case the patients already be given on the streptokinase, because if we provide a lot of anticoagulant, it will increase such a excessive blood loss. It's like really bleeding to the patient. And for scrub nurse and for scrub nurse or a technician or scrub nurse or scrub technician, so the 1 milliliter of heparin, like 5,000 units, will be dispensed in the irrigate saline that used to flood the catheter, and also the normal saline 1,000 millimeter as well to flood the catheter for preventing the blood clot in the equipment, like in catheter, in chase, or used to get rid of the blood from the guide wire to prevent the clot, something like that. So don't worry about this step. I will tell you later on in the laboratory next week. And the adverse events or adverse effects of heparin is about heparin-induced thrombocytopenia and thrombosis syndrome, something like that, and excessive bleeding, hypersensitivity, hematoma, and bruising. And here is the fibrinolytic agents. Like I told you in the previous slide about the SK, right, the streptokinase. The fibrinolytic agents is the drugs or agents that give to the patient to dissolve the clot formations. Don't confuse with the previous drug that has the action like prevent clotting, but the fibrinolytic agent is used to dissolve the clotting instead of prevent. But we account that it also prevent, but normally it's not prevent at all. It's dissolve every single clot in our body. And the general drug that used is SK or streptokinase. The action of this, you will see the SK will bind to plasminogen that already bind to the plasmid. So when we compatibly bind to plasminogen, it can cause the plasmin dislodge from the plasminogen, and eventually the clot formation will be dissolved, right? The precaution by using streptokinase, you have to ensure that in case that the patient has some a problem with the blood clotting or some GI tract, so you might see the internal bleeding like in the GI tract or something, and patient may lose a lot of blood. And after the given of the SK of streptokinase, some patient might stop the bleeding by using the vitamin K or something like that. Normally, the SK will provide to the patient who has the STEMI, like a blood clotting in coronary artery. You see the pattern of ST elevation in the ECG of the patient, and the SK normally provide to the patient in terms of the PCI doesn't quickly perform to eliminate those clots within 2 hours. So in case the patient has the heart attack or something like that that relate to the clot in the coronary artery, and the the heart center or the hospital that has the heart center that also has the cardiac catheterization is located far away, exists the transportation exists 2 hours eventually. So the local hospital may give the SK to the patients to dissolve those blood clot formation that can cause the acute MI or ACS, something like that. So SK is just a general drug that every emergency room has this drug already. It's like every single hospital has the SK to resuscitate those kind of the patient that has the heart attack. And we move to the lidocaine. Lidocaine is the local analgesia, right, to relieve the pain, account as the topical agent, some kind of that. For I'm gonna tell you about briefly in this drugs, but anyway, you have to remember about the dose of the drug as well, because you have to know that why the lidocaine is important in the cath lab, because the lidocaine will use to relieve the patient the pain of the patient while the doctor puncture or insert the catheter inside into the artery. Normally, the lidocaine will be given by subcutaneous injection, and the 2% lidocaine will be injected for 1.5 to 3 milliliter for radial access at the wrist region, and the doctor will inject the lidocaine for 7 to 10 milliliter in case the doctor puncture or use the femoral access, like femoral as the approach site. So the doctor may inject the lidocaine for 7 to 10 milliliter to the groin area. But anyway, the dose of the lidocaine also depending on the patient body size as well, or the patient patient weight as well. And the adverse events or adverse effects of the lidocaine can cause the patient dizziness or drowsiness or confusion, respiratory depressions, anaphylaxis, and also hypertension when given through the intravenous. And the last one of the pharmaceutical agent section about contrast media. Normally, the contrast media that used in the present in this moment normally, have some action that slightly protect the kidney, like to protect from the renal failure that I already told you about. Contrast may induce nephropathy, right? So recently, like especially this brand also have some action that slightly prevent the renal failure, but not 100%. So you might concerned about maximum dose of or maximum volume of contrast media as well. So the contrast media normally, no, not like the contrast media normally not directly inject to the patients. It has to dilute it with a normal saline plus heparin already in the ratio 1:1. Like when you have to use contrast media 10 milliliter, you have to dissolve the contrast media with a normal saline plus heparin for 10 milliliter as well. So you're gonna get the 20 ml or milliliter of the contrast media plus normal saline. And the contrast media, the concentration of contrast may be, reduced like, the concentration of the contrast that dissolved with the normal saline may be depending on the patient renal functions. In case the patient has the high amount of creatinine or BUN, in case that is the laboratory that reflect to the kidney or renal function, right? So in case of it, you might dilute the contrast with a lot of normal saline. But anyway, there is some a threshold for the dilutions. Like if you dilute the contrast media with a lot of solutions, like with a lot of normal saline, so when you inject the contrast into the coronary artery, you might not see, like it might not visualize the anatomical structure of coronary artery, like it's not being the contrast media at all, right? So you just can see any vessel, anything in the senior image. And the third one is about administrate the normal saline IV bolus. When after or while doing the procedure, the doctor may request nurse to administrate normal saline through IV bolus. It's just like, unconscious. It's just like stop and start. Bolus is something like that at least 200 milliliter to prevent contrast-induced nephropathy. And the dose of the contrast media for using in coronary artery imaging is about, if we use in the artery or coronary artery, right? So the maximum dose is about 370 milligram iodine per ml, because like I told you earlier that the contrast media composed of iodine, right? You have to concerned about the patient who allergic to the iodine. So those patients may allergic to the contrast media as well. And the maximum dose for procedure is about 225 milliliter per person. But from my experience, I ever saw some cases that has the CTO. It's just like chronic total occlusions of the artery, and doctor perform the PCI at least 4 hours, and the total contrast using is quite a lot. It's about 250 milliliter, I think, like that. And patient administered a lot of normal saline to prevent the contrast in the nephropathy in this kind of patient. And it's just some sharing my experience about contrast media using. All right, for take a break for 15 minutes. So do you have any questions about the pharmaceutical agent? Hello.
คำถามค่ะอาจารย์
ไม่มีเนาะเอ่อจะพักหรือว่าจะต่อ
อาจารย์ครับ I
ครับ
have one question. In anti-platelet drugs mechanism, do we need to remember the name of the receptors?
No, you don't need to remember those kind of receptor that have the mechanism that the antiplatelet drug provide the mechanism at all. You don't remember this slide. And you don't remember each kind of mechanism because it's quite hard and tough for remember every molecule or every receptor.
No, like we have particular drugs, right? For example, clopidogrel and prasugrel, they bind to the P2Y12 receptor. So do we need to remember this? Like these specific drugs bind to these particular receptors?
Yeah. You have to remember some, specific drugs like clopidogrel and prasugrel or aspirin about the mechanism of the action, and all other type of drugs as well that I tell you about the essential of this.
Thank you. Ajahn, yep. I have one question. Yep.
Uh,
Can you go to slide number 3? Causes of arrhythmias.
number T. This slide.
Yes.
Right.
Okay. In the causes of arrhythmias, as you mentioned, acidosis or accumulate of waste product can cause arrhythmias. Can you brief a little bit about this?
All right. So personally, I'm not kind of person who have a lot of knowledge about the pharmacology. But anyway, that I ever read the book before, the acidosis or accumulated waste product can cause the metabolic change in terms of the electrolyte and some kind of that. So in my opinion, I think when the sodium changing or some calcium changing or electrolyte imbalance in the cell might be cause the excitability of the action potential, but I'm not sure about this question, just in my opinion.
No, like I was wondering that how can it cause arrhythmia? That's what.
Mm, all right, so I think normally I think when the tissue has some acidosis or accumulate of waste product, eventually it's gonna have the inflammation, right? And normally when the tissue has some inflammations and some damage, it can uh, generate the fibrous or becomes the fibrous tissue, and eventually it can block the electrical conduction system through the right the atrium or some part of the heart, and eventually it can cause the re-entry of electrical conductions, and eventually it can cause the arrhythmia in some case. If we look at that, do you
Yeah, I get it a bit.
okay? But anyway, I'm not I'm not the expert
Like
one about this. Yeah.
other mentioned causes, it's quite understandable, but that cause acidosis or accumulative waste products in cardiac cells like myocardium.
Yeah.
I never read about that, like in my previous lectures also.
Of it some I think it's just a possible way about acidosis and accumulate of waste can disturbance of the electrolyte in cell, but there is no a consensus way about the physiology of this.
Oh, then I'll try to find it out.
Uh,
Thank you so.
เอาฉันเปิดกล้องอยู่ So are you ready for studying the next section?โอ้เริ่มเลยแล้วกันเนาะ
เริ่มเลยค่ะ
เริ่มเลยนะโอเค Alright, so for the next section, I would like to tell you about the advanced instruments in CAT lab. Like I would like to tell you just some, adjunctive or additional instrument that normally found or normally see in the CAT lab. That in every CAT lab probably have this kind of advanced instruments. And I think Ho Sin Chi, our guest speaker from Singapore, didn't tell you more about this kind of instrument. So I think I'm gonna add it up to you to enhance your knowledge. And I think this slide is very important rather than those previous slides that talk about the pharmaceutical agents, mechanism, some kind of that. All right, I'm gonna go for the first one. It's about fractional flow reserve device, or FFR. FFR is the device that used to evaluate the physical occlusions or physical changing of coronary blood flow in the patients. In case, you know, when the doctor inject the contrast media into the coronary artery and they see the lesions, like they see some, you know, stenosis in some part of the coronary artery, and they're quite sure that the stenosis, you know, is not too much, and the doctor not sure about the benefit of the revascularization to this to that lesion or not. So the FFR might use to evaluate the benefit of the revascularization. And here is just some brief or some grossly characteristic, or you know, the of the device and of the pressure guide wire as well. Here is the instrument that, you know, has the display and many button to control, and here is the guide wire that need to, you know, directly, you know, insert into the patients. Like the proximal part, like here is the proximal part is inserted into the patient across the lesion, and the distal part connect to this instrument, and it can, you know, evaluate the difference of the pressure. And you can see that there's kind of pressure guide wire at the tip. It composed of the optical pressure sensor. You can see here, optical pressure sensor, and the signal will send to this module, and after that the signal we're gonna convert and send back to this machine. It's just a brief principle about that. And like I told you, the fractional flow reserve is used to access the physiologic consequence of the coronary lesion to predict the benefit of revascularization in coronary artery disease, especially in the PCI, or doing like, you know, it is like, you know, we will assess that these patients is, you know, good to do, or is, you know, is the best way to do the lesions in those patients who has, you know, not like unconsensus the I mean that the lesion. It's just like, you know, when the doctor see the stenosis in the coronary artery, and like doctor not sure that if they use the balloon dilate the lesions or implant the stent to the lesions, so in the long term it's gonna get the patient's gonna get better or not. Like, you know, you are concerned that the stent or, you know, any kind of procedure that do to that position in long term is can cause the restenosis, right? And it will cause the, you know, like the patient problem is in some patients. But anyway, so if the blood perfusions through that lesions is normal, like there is no problem with the blood flow or the blood perfusion, so the revascularizations may not consider to that reason, to that lesion. And the fact about the fact about fractional flow reserve is the changing of hemodynamic condition of the heart and, you know, the microcirculation don't impact to the FFR value, because FFR value is evaluate the perfusions of blood at the hyperrhythmia or the high blood perfusions by using the adenosine injection to induce the high blood perfusions across the lesion. And you can see that the picture, the FFR value derived from the distal coronary pressure, you can see here, and this thing that insert in the coronary artery is the pressure guide wire that I tell you before, and you will see that on this pressure guide wire we have the optical sensor which will measure the pressure inside the coronary artery that's going to be located here at the proximal part and maybe later on the distal part, something like that. So when you insert the pressure guide wire across the lesion, the stenosis lesion, the FR value will be acquired by using the distal coronary pressure or PD here, that a pressure across the wrist, a pressure below the region divided by pressure above the region here, PA or proximal coronary pressure during the maximal hyperemia, or when doctor have to give or inject adenosine to induce high blood perfusion. And about FMI interpretations, like I say that normally the doctor will determine or will evaluate the fractional for reserve if the angiographic image show like not 100% stenosis, like just like doctors see the lesion that the stenosis is about 40 to 90%, as you can see on the chart. So the doctor might check about IFR. IFR is the same way to the FFR, but not measure about the perfusions at the hyperemia, like not inject the adenosines. And after the patient check about the IFR, so if the clinical symptoms are, non-invasive testing like stress test or some kind of that, consistent with ischemia, or patient has suspect to the CAD, something like that. So if the IFR greater or equal to 0.89, so the normal value is 1, right? Those patients might consider to do the PCI to that regions. But in case the IFR is greater than 0.93 or 0.93, so those patients might not consider to do a PCI, may use the drug to treat instead, or some other like lifestyle changing, something like that. And in case the IFR is about between 0.90 to 0.93, so the doctor might consider to use the FFR, like inject the adenosine to induce the hyperemia, to evaluate the exact value without any hemodynamic condition or microcirculations that affect to the value of IFR at all. All right, in case of this, if the normal value of FFR is also 1, like normal people that there is no region, is about 1. But in case the FFR values less than or equal to 0.80, those lesions might get the benefit for doing the revascularization. So those patients might the doctor might consider to do a PCI on that patient. And in case the FFR values greater than 0.80, so in case of this, the revascularizations might not benefit to that lesion, and the patients may get the drug therapy or changing their lifestyle, something like that. And when we look at another branch of this diagram, and if the patient's not like there is no symptom that relate to the CAD at all, so when the doctor evaluate the IFR, so if the value below 0.80, 86. So the revascularization or PCI may be benefit to that patient. And in case the IFR greater than 0.839, so those patients might not get the benefit from doing the revascularization or PCI and get the drug therapy or changing lifestyle may be preferred to that patient. And here is some FFR setup and preparation. Gonna show you. Boop, boop. Oops. Here is the pressure wire, right? And you can see that circulating nurse will serve this in the sterile technique, and the scalp technician already received this guide wire. Here is the hoop that contain of the pressure guide wire, which connect with the talker and also the module that connect to the distal part of the guide wire. And the things that he hold in the hand is just like the connector that connect to the instrument. Before using, you have to flood the hoop that contain guide wire with the normal saline that composed of the heparin. After that, you have to secure the connector of that module and send this end of the line to connect to the instrument. After that, you will let the circulating technician zero the pressure, right? Zero to the air because it's located outside our body, right? So you can directly zero to the air now prior to inserting into the patient. After that, you can see that the doctor will check the Y signal by tap on the hoop to see, the pressure signal just, move, amplitude of the signal just move up and down by hitting the hoop. After that, he will remove the pressure wire from the hoop. You can see that he is handle the pressure wire very carefully to prevent the contamination. And after that, at the proximal part, right, the tip of the pressure wire, he will insert to the needle puncture. And here is he will show you about the pressure sensor of the pressure wire. He insert into the needle already now. And he gonna adjust the tip of the guide wire for easy penetrate through the coronary artery rumen. Now he insert the pressure wire that in the needle to the Y connector and to the catheter eventually. After that, he gonna remove the introducer needle out, and then he gonna de-airing in the circuit now by press the Y connector to get the blood come out a bit. Anyway, for see to hear his voice, you can copy and paste the name of the clip in the YouTube, and you will know about the setup and preparation step. Now he inserts the pressure guide wire into the aorta already now. And after that, they take the introducer needle out and also lock the Y connector to prevent other cavity that let the air leak out. And after that, he gonna calibrate to the aortic pressure. And here, he gonna insert it into the coronary artery. Now, he said that he ready to measure the FFR now. You will see that the pressure between yellow and red, the amplitude of this is equal with each other. So in case of this, you mean that the FFR is value is about 1 because there is no change between the proximal pressure and distal pressure. In case of this, I think if the patient doesn't have the lesion, so it might be located proximal part of the lesion, like above the lesion. Now he slightly advanced a bit, and you can see that the yellow amplitude will be down a bit now. Now you see that the damping is caused from injecting the adenocytes, and you will see that the FFR value in this patient about 0.88. So the revascularization might not consider to this patient, like there is no significant stenocyte lesion in this patient. All right, so that all is about FFR, or fractional flow reserve, and I think this topic about the interpretations and about consideration of revascularization, I think Ajahn Muan Phet might tell you later on in the CAG and PCI topic in next week. My God. All right, so I'm gonna move to another advanced instrument that generally found in the cath lab. And here is the angiography high pressure injector that used for inject the contrast media to other part, like to other part that really used high volume and high pressure for injection. Because normally when we inject the contrast into the coronary artery, we can use the manifold and inject by our hands. So you're gonna learn about how can we set up and preparation the manifold in on next week in the laboratory class. And the angiography high pressure injector is used to assess the Lv angiogram or aorta angiogram or CT brain or some kind of that. And in the cath lab, the main point that use angiography high pressure injector or this injector is used to assess the LV, left ventricle function. So normally we compose of the instrument, and also the high pressure siren that will contain the contrast media that already mixed with normal saline plus heparin. All right, I'm gonna tell you about the indications for doing ventricular angiogram that need to use the previous instrument, which is the high pressure injector. The LV ventricular or left ventricular angiogram is the, one evaluation or one procedure to define the anatomy and function of left ventricle and to assess the global and segmental LV functions, qualitative and quantitative, and used to evaluate the mitral regurgitation, used to see what's happened to the heart structure, like ventricular septum defect or cardiomyopathy or LV non-compaction, something like that. But anyway, the catheter that used for LV injections is different from coronary angiogram because you not directly inject the high pressure of contrast media to the LV. Because if you use the strain catheter like just not just have the shape like this, like JR or JL into the LV with a high pressure, it can damage the myocardial. So the candidate used for Lv-gram, that is the abbreviation form of left ventricular angiogram. The Lv-gram would be the pigtail candidate, which has the characteristic like a pigtail and has the many side hole. Here is the side hole on the candidate, you can see it, and here is the tip hole that already have the patient inject out. So the reason that the pigtail have the side hole because it would like to this candidate would reduce the high pressure, because normally the candidate that used for the IC or inter coronary artery would have just only the tip hole, there is no side hole at all. But in some case there might be some type of the diac candidate that had the side hole to prevent the damping of the pressure, like totally obstruct of the candidate tip. But anyway, for the pigtail, there is a side hole that protect the ventricular damage. And here is the example of the Lv angiogram. I'm gonna show you about the video now. Okay, here is the normal Lv-gram. You can see that the Lv is look really not like, you can see the Lv function is normal, right? And the next one is the Lv-gram as well, but this patient has the severe mitral regurgitation, and I would like you to see this image to evaluate. All right, so you will see that after inject the contrast media into the Lv, you will see that the contrast flow back into the left atrium, right? And you will see there is a huge pulmonary vein out there, and left atrium enlargement. In this case, is very severe mitral regurgitation. I'm gonna paste again. So did you catch up this? Now you see that. Normally the flow must be come out to the aorta, right? But you will see that the flow turning back to the left atrium again. This slide shows another case of mitral regurgitation. You see that? Now you see that? It's very clear, right? Again. And you will see that when the when the flow that composed of the contrast media come back into the aorta, you will see that some flow slightly go through the coronary artery as well. You will see that just some fade or some shadow here. All right, and here is the Lv-gram that show you about the Takotsubo cardiomyopathy. Is one of the cardiomyopathy that cause the Lv function worsening. And you will see that the apex doesn't contraction at all. Normally, the Lv contraction will start at the apex to the basal, right? But in case of this, just only the basal that squeeze the blood pumping out to the circulatory system. And now we call that the Takotsubo. It's just like the Japanese octopus trap, something like that. It look like the shape of this. You will see that it looks similar. This thing looks similar to this one, right? Normally, this disease caused by too much stress and normally found in the woman rather than in the female rather than male. And the major cause of this disease is from stress or just face some, I would like to say that very heartbroken event, like, break apart with boyfriends, or, have some beloved person pass away, something like that, it can cause this disease. It's like, the myocardial stunning, that something like that. And here is the aorta angiogram, like, injection the contrast media in the ascending aorta, and you will see that AR, it's just like the aortic regurgitation. Normally, the contrast media that's mixed with blood that already injected into the aorta must be flowing to the circulation system, right? But anyway, in case of this, you will see that the flow is going back into the LV to the aortic valve. So in case of this, you might consider that this patient has the aortic regurgitation, or AR. And this is the last slide I would like to show you about Ffr angiogram field that I think Ajahn Muenpet might show you in the next topic as well. Here is the, the LCA angiogram, left coronary artery, and this one is LAD, or left anterior descending. This view would be Lao cranial, right? And this view would be the spider view, Lao caudal. You will see that it looks like spider. Like here is the left main and branching to LAD here and circumflex here, which just like the spider legs. So we can call this like spider wheel or Lao caudal. And here is the Rao caudal, which you will see the bifurcations between left main, LAD, and circumflex as well. Here is the circumflex, and this one is the LAD. And the last one in this clip would be the Rao cranial. And this part is normally, the doctor normally use this field to see the septum band on the LAD. You will see the LAD line from this to this part, and here is the septum branch of LAD. You will see just some slightly lesion here, the proximal part of LAD. And here is the right coronary artery, or RCA. This will gonna be RAO, would be RAO. I'm sorry, would be LAO. You will see the RCA look like a C letter in English, right? You will see the sinus branch and conus branch and some PL, something like that. Oops. All right, and for other additional informations or just additional contents about this topic, you will find it on this book, like Practical Manual of Interventional Cardiology, and you can search it in ebook library of our university, and I think you can access to it for free. And thank you for your attention. So do you have any question?มีคำถามไหมครับ Do you have any question? ไม่มีเนาะ
ยังไม่มีค่ะ
ยังไม่มีเนาะ Okay, so alright, if you don't have any questions, so I would randomize the case study for each group. Now you already know that you belong to each group. You belong to which group, right? I divided to 4 groups now, 1 to 4, and I would like to show you about the case study. Anyway, I'm already uploaded on the TU Moodle, but anyway, I would like to show you again. So there are 4 cases now. The case study number 1, case study number 2, 3, and 4. Now I'm gonna, have to turn on the camera หรือเปล่า so I have to So I'm gonna open the applications of Lucky Wheel นะจ๊ะSo it's easy way to do. I beg you to hit the right hand icon in this MS Team, and the first person that hit on the right hand in this MS Team gonna have the priority to select what is the questions that you would like to take to the page to the other group. I mean that when you say that I would like to start I would like to start at the case study 3 first. So in case you say that, I will hit the spin bottom here of the lucky wheel, and then if this will stop at which one of groups, so those kind of case study will belong to that group. Did you understand about that? เข้าใจอยู่เปล่าเข้าใจอยู่ใช่ไหม
อาจารย์ค่ะคืออาจารย์จะหมุนวิวใช่ไหมคะแล้วก็ใช่แล้วก็คนที่โดนเลือกก็คือให้ choose case study ให้เพื่อนหรือว่าให้ตัวเองอะ
คืออย่างนี้อาจจะฟังดูงงหน่อยก็คือในทั้งหมดเนี่ยใครก็ได้ที่กด raise hand เป็นคนแรกใช่ไหมมีโอกาสได้เลือกเคสสมมติว่าอาจารย์เลือก case study ที่2หลังจากนั้นเนี่ยอาจารย์จะกดสปินใช่ไหมแล้วพอมันสปินไปหยุดที่กลุ่มไหนกลุ่มนั้นก็จะได้ case study ที่เพื่อนเลือกไปนึกออกปะเก็ตปะ
อ๋อนึกออกแล้วค่ะ
งงวะ
ก็คือก็ต้องแยกมือถูกไหมคะ
ใช่ใช่
อ๋อแต่ว่าที่เลือกไปก็คือเราเลือกให้คนใน random view อีกทีหนึ่ง
ใช่ใช่เราเลือกให้คนใน random view อีกทีหนึ่ง
อ๋อค่ะขอบคุณค่ะ
โอเคถ้าเริ่มพร้อมเนาะพร้อมแล้วเริ่มเลยครับจะมีใครเล่นกับอาจารย์ไหมเนี่ยโอเคกัญญาได้คนแรกนะกัญญา which one of case study you may give to the randomized group ครับ
เคส1ค่ะ
โอเคเคส1นะครับเคส1นะครับ which lucky นะครับ be with you favor นะฮะอันนี้นะเห็นไหมเนี่ยอาจารย์ไม่ได้โกงนะเดี๋ยวอาจารย์อันนี้อาจารย์หมุนแล้วนะอาจารย์หมุนแล้วนะสรุปเคสสตัดดี้ที่1เป็นของกลุ่ม4นะครับเคสสตัดดี้ที่1เป็นของกลุ่ม4นะครับสามารถทำได้เลยนะเพราะอาจารย์อัปโหลดไว้ในMoodle แล้วต่อไปเดี๋ยวฝากเคลียร์ไลท์แฮนด์นะครับฝากเคลียร์ไลท์แฮนด์สักครู่เนาะอาจารย์ไม่ได้กระดาษมาอาจารย์ขอจดแบบ นะครับ เดี๋ยวอาจารย์จะลบกลุ่ม 4 ออกจาก Lucky View นะครับ โอเค alright so please move your right hand out and now I'm gonna start again. อุ้ยSo Agas and Apason, please move the right hand out. I'm gonna start again. We start again. All right. So are you ready now? Are you ready now? I'm not telling you about. อาการเดี๋ยวเอาออกก่อนนะครับ All right. 1, 2, 3. So right hand. นัทชานะครับโอเคนัทชา Which one of case study you might prefer to give to the randomized group ครับ
number 2 ค่ะ
number 2 นะครับโอเค number 2 นะครับนี่นะอาจารย์ลบกลุ่ม 4 ออกไปแล้วนะand โอเคเป็นของกลุ่ม 3 นะครับ case number 2 นะครับcongratulation ทุกกลุ่ม 3 ด้วยนะครับตอนนี้ okay I'm gonna count 1 through 3 so raise hands okay Agas นะครับ so which one of the case study would you like to take to the randomized group
case study 4 ครับอาจารย์
okay case study 4 so there are 2 groups left now for group 1 and 2 I'm gonna hit the lucky wheel นะครับand case study 4 belong to group 1 now congratulations to group 1 that you got the case study 4 so the last case study like case study 3 would belong to the group 2 3 Alright, so for the case study, I would like to announce the case study that belong to each group. The case study 1 belongs to group 4, นะครับ and the case study 2 belongs to group 3, and case study 4 belongs to group 1, and case study 3 belongs to group 2. Okay. And you can see the evaluation form that I already upload in the TU module that has the committee evaluation that me would be give you a point at least 6% because total percentage of this like the weight of this case study related to PCI is 10%, right? I'm gonna give you 6%. And about 4% you will derive from your friends, like 2% you will derive from the peer evaluation, like other member in the group will evaluate you, and in the second percent you will get by your friends that being the audience in that in the meeting room while you have the presentation. So the total point that you get is 10. So you do understand about that? No? มีคำถามอะไรไหมครับไม่มีเนาะไม่มีเนาะโอเคถ้าไม่มีก็คือ ลีฟได้เลยนะครับ
ขอบคุณค่ะ
ครับ
ขอบคุณค่ะ
ขอบคุณ
ขอบคุณ
ค่ะ
ครับ
ขอบคุณค่ะอาจารย์